Good afternoon. We appreciate everyone taking their time to be here today, their valuable time to learn about the hydrogel spacer. My name is Brian Davis. I'm professor of radiation oncology at the Mayo Clinic, and I'm the moderator today. And I have a few slides to show. We have three distinguished speakers. It'll be Dr. Zelefsky speaking first, and with a slight change, it'll be Dr. Folkert second, and concluding with Dr. Fagundes. I just have a few slides as an introduction. A hydrogel spacer, a reducing rectal toxicity in prostate cancer radiotherapy. We're using this at our institution. My colleague, Tom Pizanski, is the one who spearheaded this effort. We've been using it for over a year and have done over 100 cases with external beam, LDR, and HDR brachytherapy. Here are some disclosures, and wish to show you a simple image with the hydrogel spacer there in white between the prostate and the rectum. All of these do require that you do an MRI and you do CT MR image fusion, at least at our practice, for treatment planning. And I assume everybody can hear me in the back there? Okay. Here is an example of doing the MR CT image fusion with the hydrogel spacer outlined in green, and this is the image fusion as stated. You can also see it here between the rectum and the prostate. In our practice, for external beam patients, we actually have our interventional radiologist set up to do it. When it comes to brachytherapy, I do this along with the urologist. Here's an example of a proton case. We have a scanning proton unit. So unlike many other treatments at other centers in the past with scattered beams, they would use straight laterals. We can actually use anteriors with the spacer by separating the rectum and the prostate with the spacer here contoured in green. And finally, here's another case that is otherwise challenging to do with protons. It's a bilateral hip replacement with a patient very motivated to receive protons, and these are two anterior and two posterior non-opposed obliques with the hydrogel spacer contoured here in lavender. So without taking up further time, I'd like to introduce our first speaker, Dr. Michael Zelefsky, who's professor of radiation oncology and vice chair of the Department of Radiation Oncology, along as chief of the brachytherapy service at Memorial Sloan Kettering Cancer Center and editor-in-chief of the Brachytherapy Journal.
Thank you very much, Brian, and it's a pleasure to be here to share with you our experiences and speak about the rationale of why we should be considering some kind of rectal spacer, especially as we utilize dose-escalated radiotherapy. And here are my disclosures. So I think the real pertinent questions are, is there a clinical need for rectal spacer? This actually has been brought up in one of the earlier sessions today. In what scenarios is it important? And is there a benefit for its use? So let's talk about a moment what we know about rectal toxicity after dose-escalated radiotherapy. Conformal techniques have reduced clearly the incidence of late grade 3 rectal toxicities after high-dose radiotherapy. IMRT in particular has an established role as reducing the incidence of rectal bleeding. And nevertheless, we still see grade 2 rectal toxicities, albeit much less than what we've observed in past years. And I think if you've just been at this meeting, what's really salient and actually pretty impressive compared to prior meetings is the emphasis here at ASTRO this year of the importance and the emergence of moderate hypofractionated regimens based on randomized trials and being an established form of therapy. And we're also talking more and more about what's called extreme hypofractionated regimens as well. Here a look at some of the multi-center phase 3 randomized trials. And here we are looking at grade 2 plus rectal toxicity. And overall, the trials have shown that these are well tolerated and comparable to external beam radiation or conventional fractionated radiation. But still, what is out there is not negligible. There's still rectal toxicity, still rectal bleeding to contend with. And rectal bleeding, we all recognize, impairs the quality of life of our treated patients. And within each of these trials, even despite some of the techniques of maybe limited margins around the posterior aspect of the prostate, there is still, such as in the CHIP study, still about, even within each arm, grade 2 plus rectal toxicity, not insignificant, of 10, 13, 14%, as you see across the board here. And so as we go into eras right now of dose escalation, and we recognize how important dose escalation is in the treated patients we are currently under our programs, and generally this is for intermediate and high-risk patients in particular. These are more concerning for the higher risks of grade 2 rectal toxicities. Thus, there's a rationale clearly for the spacer. And the interventions delivering more dose escalation, it's combined modality, brachytherapy, combined with external beam radiation. We also recognize extreme hypofractionation of 5 fractions. There's a good deal of data that is out there, and trials are ongoing. The PACE trial is a very important one as well, comparing it to standard fractionation. And also recognizing the emergence and improving techniques of brachytherapy, salvage brachytherapy, which a number of centers, including ours, are using after radiotherapy failure, may be a very important scenario for the use of interventions to reduce rectal dosing. And so here is an animation of what actually is happening. If some of you are not familiar with this, the transrectal probe is placed, you see everything with ultrasound, and you place your needle into the perirectal region right here, which is that fat plane that can be seen, and then you introduce normal saline and create that plane with hydrodissection. Once you have hydrodissection, you aspirate to confirm that you're not in any vessels, and then if you're in the right location, you attach, basically in this case, the spacer, that gel, and the hydrogel that is injected into that space created with the hydrodissection. And this space can be achieving up to a 15 millimeter spacing that lasts for several months. We know from the randomized trial that was performed, where 222 patients with localized disease were randomized to receive spacer or no spacer, and all of these patients were treated with conventional fractionated IMRT to 79.2 gray. No adverse events were related to the spacer, and there was reduced late rectal toxicity noted in the spacer group. As you can see here, for late rectal toxicity, compared spacer to no spacer. And once again, here we are talking about conventionally fractionated radiotherapy, where we don't expect extraordinary high rectal toxicity, but still in a randomized setting, we were able to see, these authors were able to see a reduction in the incidence of late rectal toxicity. And here you can see the median perirectal space created with the spacer here is 12.6 millimeters. And there was, as a result, a reduction in the mean rectal dose receiving the high dose, or the V70. And I would encourage you to look at what, I've looked at this data, which looks very interesting. It's the 3-year study that will be presented tomorrow by Dan Hamstra, looking at the 3-year results with this pivotal trial, showing more of the benefit in terms of reduction of late rectal toxicity. So here's a case study of one of our patients, of a 68-year-old T2A, Gleason 7, PSA 8, treated with SBRT. This was part of our dose escalation study where we ultimately have brought our final dose levels to 8 times 5 or 40 gray in 5 fractions. And in this case, 37.5 gray in 5 fractions delivered to the prostate and seminal vesicles. Our margins, 5 millimeters, circumferentially, except at the prostate rectal interface where a 3 millimeter margin was used. And I bring to your attention right here how with the spacer, again, the volume of rectal and PTV overlap significantly reduced, as you can see here. And the dose that is exposed to the high dose region, looking at the V3750 centigrade, was again reduced as well. Here's the DVH, dose volume histogram of spacer and no spacer, and you can see that across the board, the spacer versus no spacer, a reduction overall across the entire spectrum of the DVH for reduced rectal dosing. And one can see here as well, here is the CTV, the rectal, anterior rectal wall right here, and the spacer creating a significant separation between the posterior aspect of the prostate and the anterior rectal wall. And again, here's the 50% isodose line here, and really not cutting in at all to the rectum as well. No spacer, and with spacer, you can see the sparing of this 50% isodose line, which normally cuts through the rectum, as shown here, and again, substantial sparing at this point. Now, again, some, I would say, and we've have seen this in earlier talks at the meeting, some with even extreme hypofractionation have very low incidence of rectal toxicity, and I think it depends heavily upon the margins that are utilized as well. If you're using extraordinarily tight margins, maybe margins that are so tight that are not giving anything, you may not need a spacer. But if you use margins which I think should be appropriate because of organ motion of 3 millimeters or the like, I think the utilization of a spacer is indeed helpful. We even used a spacer and separator between the prostate and the rectum, yes, for SBRT, as we see here, and it beautifully shows up in this sagittal image here, as you can see, between the rectum and the prostate. And again, as Dr. Davis had mentioned, you really can visualize this only with MRI, and to get the most appreciation, either doing this with MR-based planning or MR-CT fusion. We've done this following at the time of the procedure of LDR. As you can see, the seeds placed here, and again, with this palladium implant, during the life of the implant, until this dissolves, there's really minimal, if any, rectal dose that is seen. So these are my personal perspectives. What are the advantages of any spacer in conjunction with high-dose radiotherapy? It's the established demonstration of increased separation of the anterior rectal wall from the posterior aspect of the prostate. We have seen and observed consistent reduction of high-dose exposure to the anterior rectal wall. And as rectal toxicity is linked to the volume exposed to higher doses, it just follows logically that grade 2 and higher toxicities, which have been observed with moderate hypofractionation, may indeed be further reduced with the placement of a spacer. And fistulas nowadays are indeed very low in their incidence, and I would say with well-delivered radiotherapy we recognize less than 1%. But the incidence should be certainly a rarity with spacer placements. And again, when we utilize our planning, we try with all of our techniques and with our treatment planners to minimize the dose to the rectum with all kinds of techniques utilizing IMRT and IGRT. And if we have an opportunity to create a greater separation and done with minimal, if any, toxicity, this is an opportunity as well. So here are our indications for the use at MSKCC: SBRT, extreme hypofractionation, the combined brachytherapy and supplemental IGRT, brachytherapy in the setting of prior RT, where recurrence after external beam, or prior RT in the setting of somebody who's had seminoma treatment or rectal cancer, pre-op RT. And I think this could be considered as well, and we've done it, for brachytherapy even in inflammatory bowel disease patients, which we have avoided at all costs. I think in selected patients this can be considered. So I conclude with this slide, and these are my personal impressions. From our experience utilizing this, no significant acute symptoms with the exception of rectal fullness or discomfort for several days, addressed generally with anti-inflammatory medications. The spacer is best seen on MRI, so CT MRI fusions or MRI planning, that we're utilizing now at Sloan Kettering, is needed to take advantage when contouring. In most cases, significant separation can be achieved of 8 to 15 millimeters between prostate and the rectum, and observed rectal dose reductions, especially across the spectrum of rectal DVHs, can be seen, which I believe is a true benefit for the patients that we treat. Thank you for your attention.
Dr. Zelefsky, thank you very much for that presentation. Now we're going to have Dr. Michael Folkert, Assistant Professor at UT Southwestern in Dallas, come up and give his talk on SBRT and SABR.
All right, so it's a great privilege to be here and be able to speak with all of you about our work in the spacer, and also particularly be able to follow in the footsteps of my trainer and mentor, Dr. Zelefsky. I'll be speaking about opening the therapeutic window for SBRT or SABR in prostate cancer. Augmentics provided the spacer material for the patients enrolled in the described clinical trials that I'll be talking about next, and I have no disclosures and have received no compensation or honoraria from Augmentics. So the background for my talk, we did phase 1 and subsequent phase 2 series at UT Southwestern, where we were escalating from 45 to 50 gray in 5 fractions for the treatment of low and intermediate risk prostate cancer. The goal for this high level of dose escalation was to provide a dose that was a very potent ablative dose, and that would be giving a higher biologic effective dose than any other treatment, including combination brachytherapy and external beam radiation therapy. A rectal balloon was used to stabilize the prostate, and this is just an example of one of our plans from that particular trial. In this phase 1 study at the first dose level of the 45 gray and 5 fractions, Dr. Timmerman did an anoscopic evaluation of all of the first 10 patients at 6, 12, 24, and 36 weeks after they received ablative radiation therapy, and 100% of the patients had an ulcer in the anterior portion of the rectum, corresponding to that high dose overlap region on the SBRT plan. And in this group of patients, they continued to be watched, and the mucosal lesion shrunk away and disappeared in all the 10 cases at 24 to 36 weeks post-therapy. So the dose escalation was based on a 90-day toxicity, and so since there was no significant adverse events during that 90-day period, the protocol was successfully advanced up to 50 gray, and it was considered to be tolerable, and patients were then treated at that dose in a phase 2 setting. During the long-term late effect analysis of that study, an unacceptable rate of high-grade rectal toxicity, 6.6%, resulted, and 5 of those patients required a colostomy, basically to allow that ulcer to cool down and heal, because it wasn't healing in the setting of continued stool passing by it. Those colostomies were able to be reversed, but still that's a very drastic procedure to have to undergo after getting prostate radiation therapy. So the treatment plans of these were examined, and so this is from Dr. Kim's paper that was published back in 2014 looking at toxicity, and it looked at for a example patient that had both a grade 2 acute and a grade 3 delayed rectal toxicity. We see a plan here where there's a large expanse of 50 gray overlap with the rectum. And then there's also a significant overlap at the 39 and the 24 gray isodose lines. And another example of a patient who had only grade 1 acute and delayed rectal toxicity, you see that there's just a tiny, tiny overlap with the 50, small overlap with 39, and a large overlap with 24 gray. And this just gives an example of what the biological consequences of the rectal wall irradiated to that doses are. 24 or 39 gray effectively reduces your clonal proliferation, your ability to have stem cells go over and fill a hole. 50 gray will cause an ulcer. And so when you see with denudation of the villi in the 50 gray dose range. So we analyzed the data, or Dr. Kim analyzed the data to determine the clinical and radiation dose parameters that might have been related. They found that grade 3 delayed rectal toxicity was correlated with the volume of rectal wall receiving 50 gray, greater than 3 centimeters, and that's that direct vascular stromal damage causing denudation of the villi and significant damage to the wall. And then treatment of greater than 35% of the circumference to 39 gray seemed to deplete the stem cells that would have gone over to heal that damage. And then in the lower dose range, grade 2 acute rectal toxicity was correlated with the treatment of greater than 50% circumference of the rectal wall to 24 gray. So based on this, we pay very close attention to those particular dose levels. Those are ones that were incorporated in subsequent studies. And so we know that rectal toxicity is a known issue with external beam radiation, and there does seem to be an association with higher radiation doses chance of cure, but increasing dose increases your risk of acute injury. So we partnered up with Augmentics to incorporate their FDA-approved therapy to add the SpaceOAR into a study involving this very, very high fractionated dose. And so the high dose per fraction, 9 to 10 gray per fraction, seems to be very effective. Recent publication from our group shows 100% control for low risk and 98% for intermediate risk. And that includes unfavorable intermediate risk, people with relatively high volume Gleason 7-4 plus 3 disease. So this very potent dose seems to be very helpful in terms of getting control. If we need to be able to do that, though, by delivering it safely. So we then chose the lower dose level of 9 gray times 5, which is roughly potent to combination brachytherapy, assuming an alpha beta of 2.5, and then much higher, assuming an alpha beta of 1.5 if you're an alpha beta sort of person. So our current protocol, which I'm the principal investigator on, is a phase 2 study of SABR for low intermediate risk prostate cancer with the injectable rectal spacer. The eligibility is prostate cancer with a PSA less than or equal to 15, Gleason scores up to Gleason 7-4 plus 3, CT1A through CT2C, either clinical or radiographic, no metastases, and an AUA of less than or equal to 18. We enroll our patients, we scan them prospectively under simulation conditions without the spacer. We then place the spacer and assess for spacer-related toxicity at the same time that we put in the fiducials. We do it both transperineal approach. We've done it both in the operating room and also under local anesthesia in the clinic. We assess for acute toxicity from that. We simulate under the SBRT conditions. All patients must get a treatment planning MRI so that we can estimate the spacer distance. We treat them with 5-fraction SABR. And then we repeat the imaging at 1.5 or 3 months. In the initial part of the trial, we've actually stopped doing that at this point, and we do an anoscopic evaluation for all patients at 6 weeks, 12 weeks, 6 months, and 9 months, and then follow for toxicity and PSA control with a planned duration of study of 10 years. So the primary endpoints of the study, first and foremost, are to determine whether or not SpaceOAR will reduce rates of ulcer formation and the ability of SpaceOAR to create greater than or equal to 7.5 millimeters of space. And our study design had a 90% power to detect a significant reduction in mucosal ulceration. Secondary endpoints of the trial are to assess the spacer's efficacy in decreasing the rectal circumference from that receives 24 and 39 gray, those key dosimetric parameters that we discussed earlier, and to assess toxicity, GIGU toxicity, oncologic outcomes, and quality of life. So at this time, it's nearly complete. We have 42 enrolled patients out of 45 at 2 institutions, and there's just a few left at Sloan Kettering. It might be up to 45 by now, and so we'll check that in. And then due to favorable results, we can't say the exact numbers right now, but we have started offering this as a protocol treatment as a standard option for patients. For protocol dosimetry compliance, this might be very hard to read, but when you're giving these very high doses, you have to have a lot of very tight constraints. And so we track 21 separate critical organ dose constraints and 4 target coverage guidelines. If you exceed the protocol specified limits by more than 2.5%, that's a minor violation. More than 5% is a major violation. And so a number of PTV coverage characteristics. We track doses to spinal cord, cauda. We're not necessarily worried, but we're still going to keep track of these doses anyway. Sacral plexus, rectum, looking at these circumferential doses and maximum doses. The small intestine, prostatic urethra, bladder wall, penile bulb, femoral heads, and skin with and without folds. We're tracking the neurovesical bundle doses as well as the seminal vesicle doses. And so thus far, we've been able to assess the protocol dosimetry compliance for 39 of the patients so far. In terms of target coverage guidelines, there have been 2 major violations, 1.3%. Both of these were violations that were committed in order to protect the rectum from that 39 gray overlap dose. In terms of critical organ dose constraints, there were 14 violations, 10 of which were major. 2 involved violating the low-dose circumferential constraint of the rectum at 24 gray. We've viewed the 39 gray as an absolute. The 24, we were willing to accept some violations there. 2 involved the maximum point dose to the bladder, 5 involved the volume constraint to the bladder, and 1 involved a volume constraint to the femoral head, basically because someone had a hip prosthesis on one side, so the dose spilled over too much on that side. And so in terms of spacer quality, the primary endpoint of the trial is to determine the ability of SpaceOAR to create greater than 7.5 millimeters of space. It's powered to have a less than 6.5% margin of error for the estimated rate of space creation. We've been able to assess 37 patients so far this endpoint. Our median space is 11.3 with a range of 6.6 to 21.1 millimeters. Only 1 patient has not met the goal. We graded the quality of the spacer in terms of how well it covered the apex space and the mid, and as well as how lateralized it was. Our apex distribution was suboptimal in about 30% of patients. Lateralization was suboptimal in about 40% of patients, but even with a suboptimal dose distribution, we were still able to meet the critical dose parameters that we were trying to do, and there was no association between suboptimal spacer distribution and those patients that did have a violation of rectal dosimetry. So even a suboptimal spacer is still going to help out in helping you meet the dosimetric goals. And these are some examples of what I mean by spacer quality. So this spacer is well lateralized. You have good coverage all the way across the prostate. However, we did not do a very good job of getting it down to the apex. Here's one with poor lateralization where we've got great coverage on the right but nothing on the left. So our dosimetrists had to work to use that in order to be able to get a good plan, but they were still able to achieve it. And this is an example of one with both good lateralization and good apical coverage top to bottom. And so we've done a matched comparison of the patients who were treated on the initial phase 1, phase 2 trial to the patients on the low intermediate risk trial. The initial ones all had a rectal balloon. Ours, of course, all had a spacer. And so in dosimetric comparison with matched by size and the PTV volume, the rectal circumference obviously was bigger for the rectal balloon because it's being stretched out to be larger. But across the board, I mean, for the rectal dose parameters, the SpaceOAR significantly improved our dosimetric parameters compared to the balloon, including the critical V50 circumference, getting the 50%, 33% high dose circumferences down. Didn't change the bladder wall Dmax, but interestingly, it did decrease the volumetric dose to the bladder wall. And this is an area that we're looking at in terms of investigating some of our grade 2 urinary toxicities. So as part of the protocol, we're also doing a direct comparison of plans generated pre and post spacer for all patients. So these are then matched themselves. Here's an example of an optimal pre-spacer plan where you see a significant overlap, the red 39 gray dose line and the 24 dose line with over a third and over half of the circumference. With the spacer, the 39 gray dose line doesn't even touch the prostate, and we just have a small overlap with the 24 gray. So we're also moving on to high-risk prostate cancer now with the spacer, and we've opened our phase 1 clinical trial of stereotactic ablative radiation therapy of the pelvis for patients with high-risk prostate cancer. This is patients with PSA greater than 20, Gleason 8 or higher, CT3 to T4, no metastases, AUA less than 20, and no prior TURP. And so with this one, the patients are enrolled. They undergo, they are going to receive neoadjuvant, concurrent, and adjuvant hormone therapy on this trial. And so they start off with the hormone therapy and the spacer placement. They're simulated and planned, and then the actual MRI, the lesion on MRI is contoured by the radiologist and incorporated in the plan. They receive SBRT. And then they're tracked, and then they receive 2 years of hormone therapy and are tracked for a minimum of 10 years at our institution. We started at a dose level of 9.5 gray to the prostate and the proximal seminal vesicles, 10 gray to the MRI-defined lesion within the prostate, and 4.5 gray to the pelvis. So these are all simultaneous integrated boosts, treating the pelvis, prostate, and the lesion inside all at the same time. We've treated the first. So here's an example of the plan where we are treating all the way up to the L5-S1 interspace, classic nodal coverage, and the prostate, and then the MRI-defined lesion getting the dose escalated portion. And we've enrolled the first 7 patients, and they are currently being assessed for a DLT. We're in the break phase right now. We're waiting to see if we see any toxicities at the first dose level before we move on to the next. And we're considering expanding some other institutions there. And so, and that's the status of our protocols, which hopefully we'll be reporting the final results soon.
Dr. Folkert, thank you very much, and we will have time at the end for questions. And our last presenter is Dr. Marcio Fagundes, who is at the Proton Center in Knoxville, Tennessee, and he has performed over 290 cases of SpaceOAR, which is, to our knowledge, the most extensive experience of any individual or center. So please welcome Dr. Fagundes.
Good afternoon. Thank you, Brian, for the introduction. So, yeah, when we thought about this topic back in June, July, we had 250 patients, and so we updated the topic from the announcement to 290 or over, actually, this week. So here's a picture of a proton center in Knoxville, and one of the unique things about it is that we are a freestanding center. Yep. So from the get-go, we had to do these procedures as an outpatient. Just to, here are my disclosures. So 290 patients done outpatient with local numbing between April of 2015, right after the product was released from the FDA. Pre-medication, basically, we use Valium, hydrocodone, antibiotic, Emla cream on the skin, local numbing with lidocaine. And this is very important. You have a nurse handing you needles and so on, but you have maybe an assistant or somebody in the room also talking to the patient. In this picture, I have 2 nurses, but somebody who's going to talk to the patient and so on, distract the patient. Sometimes somewhat anxious patients need extreme distraction measures, which we can do that. We can do that, it's not a problem. So I was tasked with looking at our experience and not necessarily going over the usual case, but talking about the challenges and talking about large cases, large prostate cases. And our very first challenge is a physician who actually happens to be a urologist himself. Now, this patient was already planned to undergo treatment within the rectal balloon, and then the announcement came that the gel was released by the FDA. So we had already planned this patient to start treatment with balloon, and here's his rectum V70 of 8.7%. When we started, we made a point of doing an immediate pre-gel CT scan on every patient on the first 4 patients on that very first day that we did 4 cases. And so here we have the pre-gel CT, which we took the CT and ran a plan. And we have a V70 of 10%. And then we went ahead and put the gel in and did his planning CT, and his V70 became 0. Now, I must say that this is a high-risk patient that was treated to 78 with nodal treatment, so this V70 of 0 is with nodal treatment included. So here it is, the very first 4 patients that we did on that day. The margins, you can observe that are 6 millimeters elsewhere, 5 millimeter posterior following the trial margins that they used. And the point I want to make here is that not all of these 4 cases, the very first 4, are perfectly symmetrical, but nevertheless, the V70 dose is extremely low. So very favorable dosimetry despite some asymmetry in the gel. Another challenging case is a patient that had prior history of TURP and anal fissure surgery in addition to hemorrhoid surgery, and so expected to have some scar tissue. This was our 5th case. And as we can see, this is the post-gel MRI. We did not have hydrodissection reaching the base, nor did the gel make it well to the base because of adhesion. And there was no lateral, ideal lateral dissipation of gel, but nevertheless, separation was achieved. And here's the plan, and his V70 was 0.3, and he was very happy with his hemorrhoids and history. He did not want to have a balloon. This is a recent case that we had. A patient that had prostate cancer treated in 2007 with external beam radiation following low anterior resection and chemotherapy. This patient had significant urinary symptoms. He was not an ideal candidate for brachytherapy. He was not a surgical candidate when he developed prostate cancer in 2016. Relatively large prostate, some urinary symptoms, and we said, well, if we can get gel to get good separation throughout base to apex and good lateral separation and dissipation, we can lower the rectal dose enough that we can make this treatment very safe. And here we are looking at the proton plan, lateral fields. This is the prior surgery, the anastomotic line, anastomosis line. And his V70 was 0, but not just that, his V50 was only 0.25%. So this patient did very well throughout treatment. So to date, we have, when I did the slide last week, 290 patients. I just want to point out that 16.5% of these patients are high risk, so they're typically treated with nodal treatment, either lateral opposed or a PA. Here you see the fields. But I want to focus on this. The challenge is the large glands. And I picked this because the pivotal study did not include patients with glands larger than 80 cc's. So we looked at the population that we did, patients between 80 and 100 cc's and then greater than 100. And we have about 9% of patients that fit this criteria. So you look at this ultrasound image, clearly the prostate goes beyond the grid laterally, and for those who do brachytherapy, this is a big gland. On a sagittal view, it's bigger than the field of view of the scanner, ultrasound scanner, which is 5 centimeters in my case. Big prostate, but you can still do this. So large prostates, this is a case of a prostate with 170 grams, technically more challenging, but very doable. What I do on this case is I have a sleeve with saline here to cover the probe to see where the rectal wall is, and I inflate and deflate the sleeve just to clearly see where the wall is, and now you can figure out, well, this is where the needle has to go. So we're going to watch this video. The needle has to make it over the rectal hump right here, but under the prostate, remember, we're going to go right here. So we're slowly advancing the needle. I'm keeping the cursor where the needle has to be heading, and right there. Now the key thing here is that you inject saline, you open the space, that gives you a few seconds to advance the needle, and then you inject more saline, open the space, and you advance the needle a bit more. And you have to do this step by step in a large gland because the space will collapse with the size and weight of the gland. So here is a large prostate, very good rectal sparing on a patient that had a 1 centimeter separation for most of the length of the gland and the V70 of 1.8%. One thing that I picked up early on was that, and I get this question a lot, is how do I improve symmetry? And as you're in the process of doing hydrodissection, you go back to your axial view and make sure that the needle is midline, but more importantly, make sure that the saline dissipates both left and right, somewhat or perfectly symmetrical if you want to be a perfectionist. If it doesn't do that, you can always reposition the needle to the opposite side to counterbalance that. So here's a video showing I'm going to inject a cc of saline as the video rolls, and you're going to see the saline is going to go left and right. First, I'm moving the needle, make sure it's free in the space. See the saline, it goes left and right. I'm going to do it again. That's it. So I know it's going symmetrical. It's going to, the gel will follow the saline typically. So another large gland outcome, 176 cc, 1 centimeter separation, V70 0.79%. You just look at the symmetry, looks great. Gel produced, good space, excellent symmetry, exceptional rectal sparing. So just showing you a table of these cases. The 14 cases that were between 80 and 100 cc's, mean size of 86, mid-gland separation of 1.29. The smallest separation was still 0.83. V70, 1.2%. When we looked at the prostates that were over 100, there were 12 of those. The mean size was 130, mid-gland separation of 1, mean V rectum V70 of 1.2. We can also look at the cc of rectum receiving dose. You see it's less than 1 cc. This is a poster at this meeting. I just want to show this to illustrate. This is the earlier experience. It included our first 62 patients. And what we've done in evolving rectal sparing with proton therapy is gone from using a balloon with uniform scanning where you can't really shape the dose to avoid the rectum, where the V70 was 7.7%, to using pencil beam scanning with balloon, where we are able to shape the dose away from the rectum, somewhat improving the dose sparing, now to adding gel. And when we look at the histograms, the dose with pencil beam scanning, proton, and gel is much superior. So in essence, pencil beam scanning proton therapy improved rectal sparing when compared to older proton uniform scanning in patients treated with balloon. However, the lowest rectal doses were achieved with a combination of pencil beam scanning proton therapy and hydrogel spacer, particularly in the high dose range of 65 to 78 gray. So in conclusion, we've done 290 hydrogel placements performed without complications as an outpatient procedure with local numbing. Hydrogel improved rectal spacing when compared to endorectal balloon in patients treated with pencil beam scanning proton therapy. Hydrogel can be successfully used in patients with larger glands, above 80 cc. Certain technical adjustments may improve your gel separation, symmetry, and distribution from base to apex, especially in the larger glands, and I'd be happy to talk to those interested in more detail about this. Is beyond the time that we can cover here. Patients are increasingly seeking gel as part of their treatment. This is key, and since using the product from when it was first released to now, I've seen the trend is quite obvious. I want to take the opportunity to thank ProVision and the entire staff for the excellent work we developed in the past 3 years and for supporting my initiative to introduce SpaceOAR very early on at our center. And I look forward to continued collaboration with colleagues as I transition to the Miami Cancer Institute, where we will be using SpaceOAR with MRT, IGRT, SBRT, and proton therapy going forward. My experience, in essence, on every weekly checkup and follow-up visits is that the rectum's truly like gel. Thank you.
Dr. Fagundes, thank you very much. We do have some time for questions. If you have a seat. Somebody will be roaming with the microphone.
For this huge prostate, the 10 cc was enough to give you the 1 centimeter spacing over 5 centimeter length, or you have to add more than 10 cc's of gel to cover?
The key is distributing the gel along the length of the prostate. So if you're talking about a longer prostate, the technical adjustment that you need to consider that I've learned is that you have to start the injection with the needle past mid-gland. It's a little bit different than the standard way that we all learn and that we teach. And then you actually inject the gel and pull the needle back slowly as you inject, but very gently. You don't want to over-inject gel at the below or at the apex. So there are variations and ways to do that. It is sufficient, 10 cc's is sufficient. It will be located mainly centrally, and that's why it's so important to have the needle at midline and not have lateralization of the gel. So avoiding lateralization and avoiding concentration towards the base, not enough at the apex, is key, especially for larger glands.
So how stable is the gel volume over the 5 weeks of radiation treatment when we do the SIV for high-risk prostate, for example? So is there any change on weekly basis for the rectal volume, or it is very much stable?
I mean, I can answer on the, we've done routine QACT scans on these patients, and we've seen that there is no variability in dose. There are very rare cases that may have some change in rectal filling that need more intense use of stool softeners and so on. But on the rectal spacer shape and separation, the patient that was retreated, I made a point of doing an MRI to reassess his gel at the 6th week of treatment, and it was identical. Again, I have that, but I didn't show it here. So, but routine QACTs document that the dose sparing is maintained.
We have observed that as well, but only anecdotally, that when we've, in selected cases, have re-imaged patients, we've seen consistency in terms of the geometry of the gel as its location and its shape.
And it's something we were also tracking on the trial with both cone beam and the early imaging afterwards. And we haven't seen over the period that you're treated with hyperfractionated treatment, there's no change.
Likewise, we've done over 100 cases at our institution. We do serial cone beam. Now, granted, that's with CT scan, so it doesn't always give the same image with MR, but we have not noticed any difference in anatomy between the prostate and the rectum appreciably with serial cone beam done on a weekly basis with an 8-week course of external beam. I have a question for the panel. We're doing a case of salvage brachytherapy within the next several weeks. Have you noticed any difference in placing of the hydrogel spacer in those patients that have received prior external beam radiation? Anyone?
We've actually used spacer for patients who've had failure after either external beam radiation or in some cases actually SBRT. And in those cases, especially those who have been treated many years prior, there is a good deal of fibrosis that sometimes can be encountered, especially as we've done salvage brachytherapy. And in those cases where there is a good amount of fibrosis, sometimes during hydrodissection you don't get that significant opening that you would normally see in the untreated patient, and so you may end up with less amount of hydrodissection, but we've still seen good spacer placement in those cases. In 1 or 2 cases I've noted that there's been really no good opening during hydrodissection, and those are cases that I decided to abort and not place the spacer.
I haven't had an issue with prior radiation yet. We haven't, all the people on the trial have not been allowed to have prior RT, but we have run into some patients who've had infections post biopsy, and they can be very scarred down. And I've had a lot of trouble getting a good uniform distribution then. So radiation's one issue that can give a bad spacer distribution, but prior infection or other procedures can do it as well.
So different institutions have different logistics with respect to, say, radiology and urology. Just to ask the panel to comment, who is placing the spacer at their institution?
So we've shared it at our institution. If a patient comes to see me, I place the spacer. If they come through the urology department, then often the urologist will place the spacer. When the urologists do it, they do it in the operating room under general anesthesia, and when I do it in the clinic.
Prior to the advent of spacer for our institution, we routinely had our urologist place the fiducial markers transrectally, and with the availability of spacer, we in radiation oncology are the ones who place the spacer at the same time as placing the fiducial markers. And I think it's an opportunity to place the fiducial markers exactly in locations which are optimal for image guidance, and I think it brings it back into the turf of the radiation oncologists. And I think it is an opportunity as well for radiation oncologists to utilize it, especially those who have prior experience with using an ultrasound and a brachytherapy setup. But there are many places, as we just heard, where urologists are involved, and in some cases interventional radiologists have been involved in the placement of the spacer, but I still think the radiation oncologist should play a role in being present, or at least having close contact with the urologist in those cases to make sure that it is done correctly and according to appropriate guidelines.
We have some more questions from the audience.
I'm wondering if you would extend the spacer to include part of the base of the bladder as well. Is there any way to inject it furthermore to space as well the base of the bladder or not?
I don't know if any of the panel members quite heard the question. If I could
ask. You repeat it?
Yes.
Are you asking if it's possible to protect the base of the bladder by putting more spacers superiorly?
That's right, yeah. So
Okay.
instead of just only separating the prostate from the rectum, if we can, I'm not sure if this is available, to extend the needle in some way to add some gel between the base of the bladder and the prostate.
I mean, it's physically possible to get the needle up there, but you're losing the bounding walls of that space at that point. So if you injected a lot of spacer up there, it'll just end up in the cavity. So it's hard to get good coverage, in my experience, up there.
I think that tissue plane is a lot more difficult to separate if you've ever kind of scrubbed in on prostatectomies versus the tissue plane between the prostate and the rectum.
Dr. Zelefsky outlined certain situations in which they're using the spacer. It sounded like at the Proton Center you're using it on all cases. As a community radiation oncologist, should we be using this routinely? I don't have protons. I assume my dose to the rectum is worse than yours with protons. Should I use it on everybody? And if not, why not?
So we discuss with patients the existing data and offer the option. Basically, most patients choose to do gel. And in fact, one patient recently started treatment with balloon because he didn't have coverage and would have to pay for gel. After 2 treatments, he couldn't tolerate the balloon and asked me to convert him to gel, which I did reluctantly, but it was this 3rd fraction, and everything went fine, and he skipped 1 day of treatment and then continued with gel, and he never regretted it. Basically, the patients do so well. They don't have the inconvenience, nor the issues of during treatment, balloon placement, some bleeding, and we know that happens. They just choose it and they do better. The therapists love it. It's just a better way to do treatment.
I think also you have to recognize that at least the pivotal trial that was used for a spacer, which has been published, and there is now longer follow-up that's going to be presented tomorrow in the late-breaking abstract session, indicates that even with conventionally fractionated radiotherapy, which went up to 79.2, so it's dose escalated, but conventionally fractionated therapy, there appears to be a persistent and continued benefit in terms of reduction in late rectal toxicity. Albeit we don't see very high incidence in general with IMRT and IGRT, it was still able to be demonstrated this continued reduction in late toxicity. So I think based on an established randomized trial, there is evidence that even in the conventionally fractionated patient, there may be a benefit. I think it's also very attractive, and that's what we've used it in our clinical practice. We have the term, and I've sort of marveled by it, moderate hypofractionation. It's always nice to be moderate. When you start talking about extreme, that really gets into very shaky territory, but that's the terminology we've used, extreme hypofractionation. And I think patients get, if they heard about extreme hypofractionation, they probably would be a little bit wary about that. But interestingly, I think when we talk about hypofractionated therapy at 5 fractions, I think patients find it very, at least enticing, And certainly when you start using this and you're seeing the significant reductions in rectal volume exposure, it makes it more easy to be able to deliver these kind of doses, high doses, in a much more comfortable and what appears to be a safer way.
Yes. As one of the users of extreme hypofractionation, I definitely would not do that without the spacer at this point. But I've been using also, whenever possible, I've been using it for every other application, for dose-escalated external beam, for combination. The only one that I haven't used it for is for LDR brachytherapy, because I don't feel it might offer the same benefit, but it's something that I definitely want to look into more.
Do we have any more questions from the audience?
Sure that's working. As a follow-up to the procedure of doing it, with doing it without IV sedation, the probe tolerability is an issue. And have any of you used a lidocaine Urijet per rectum to try to distribute any lidocaine in the rectum to improve the tolerability of the probe?
No, that really hasn't been an issue. Just doing pre-medication is sufficient. Basically, patients feel the most is the burning of the lidocaine going in when you're doing it, just like when you go to the dentist. But once that effect is in, they do very well. It's really not a big deal. Just distracting the patient, getting his mind off of what you're doing is really the key. And so having somebody in the room doing that for you is important.
Is there another question?
Just one, especially for Michael and for Mark. Do you think that, okay, you demonstrated that the routine used for gel is a good idea for reducing the dose to the anterior rectal wall, but in a SBRT purpose, do you think that it would be useful, a more volume gel for reducing also eventually the neck of the toxicity to the neck of the bladder? Because this is a problem that gel up to now is not easy to interest it. What do you think?
I didn't quite catch what you were saying. I'm sorry. You were asking if more volume
yes,
of the spacer.
I'm looking about eventually a special volume, a special more a probe. A convection for not for standard fractionation, but just for SBRT purpose that has more volume in gel, so you can spare rectal toxicity and bladder toxicity.
Mm-hmm. I mean, at least for some of the patients that we've had on the high-risk prostate cancer protocol, where we're treating a much larger area, we have actually put 2 spacer kits in to get a little bit more coverage, because we're treating the seminal vesicles to a very high dose. So more spacer is usually helpful.
Okay.
So the more space you get, the better.
So you use twice?
We have.
Okay,
yeah.
great.
Yeah.
Mm-hmm.
Do we have any other questions? Dr. Shasha, you must have a question or two? No? Okay. Could you discuss, Marcio in particular, any discomfort that patients have, or even in some of the rare cases?
Well, I think that with the patient awake, you may find that, 1 out of 10 patients, he's going to tell you this is as bad as a biopsy, but 9 out of 10 are going to tell you it's better. The sudden discomfort of the injection of the gel is basically what they feel, and they may say that lasts 5 or 15 minutes, but you just tell them in advance, this is how this is going to work, this is what we're going to do, this is how long it takes for this to resolve, and that's it. I haven't had a patient tell me, I wish I had done this under anesthesia, and it's just a matter of doing it meticulously, gently, not rushing it, not rushing your numbing, because if you rush numbing, you cause more burning, more pain. Just do it gentle.
So I think we're out of time. I'm sorry.
Hi, sorry. I just had one question about the numbing medication. So if you're using the lidocaine, is there any contraindication to mixing it at the time that you're injecting it with some bicarb to reduce the burning?
Oh, forgot to mention that. It is buffered, sorry.
Thank you.
Any last questions, or we're running just a little past the allotted time, and we're going to be available here for some moments afterwards if you have some questions one-on-one, or members of the Augmenic staff, Paul Walker, Tony Vaselli, could also answer questions. Thank you very much. And thank our speakers very much for their efforts today.